Hey, this is your boy, the Nebo, Psych NP, coming here with Ms. Janelle. So introduce yourself, Ms. Janelle.
Hi, I'm Janelle. I am an RN, currently an FNP student. I'm glad that I'm here and that you invited me.
Oh, thank. Yeah. So what we're going to do today is the first episode of Med Mondays with Moyo. And I'm glad you're going to FNP school. Are you going to go to Psych NP school or just FNP?
Just FNP.
Psych is where it's at.
Oh my goodness.
Psych is where it's at.
I don't know. My family's enough crazy that I need right now.
Yeah, because because I've got FNPs in my practice right now that are going to school for the psych certification.
Oh, okay.
A lot of them.
I mean, if I ever decide to, I will ask you for some tips on how I can.
Because what happens is that a lot of people go to psych FNP school, then they go to work at these places, and then the doctors tell them to prescribe psych medications. So insurance companies were like, no, we're not paying.
Yeah.
We're not paying for an FNP to prescribe psych medications.
Yeah.
That's not within your class.
Yeah.
So go back to school.
I think if you're not used to a lot of the psych drugs, because you hear a lot in school how dangerous and side effects all these are, and if you don't have a lot of familiarity with those drugs, I feel like people can get intimidated, especially like new grads and things like that. It's very intimidating.
And also now the insurance companies won't pay for FNPs prescribing psych meds. So those are most of them have to go to school for an extra year for a psych certification.
Oh, okay.
So that's the tip. Just go back to school, and you're gonna get more money.
Yeah, I mean that is true. You would have to talk to a psychiatrist to get them if you need psych meds. You can't be a regular FNP or a general doctor. You have to ask a psychiatrist for it.
Yeah, because many places what they were doing was having FNPs prescribe psych meds. They were hiring FNPs to prescribe psych meds. So insurance companies were like, no, we're not doing that anymore. No,
yeah, you need to be
gotta
certified.
go to school.
Yeah. I get it.
So anyway, today is the first episode of Med Mondays with Moyo. So what we're gonna do is talk about all the meds from ADHD to PTSD. We're gonna talk about the medications one by one. We've got ADHD medications, we've got anxiety medications, we've got bipolar medications. Do you know anything about these conditions?
Oh yes.
Yeah.
I mean, as much as you know, back in the 90s, it was something that you didn't talk about. I feel like a lot of people are talking about these different diagnoses that are coming up. You got anxiety, you got bipolar, depression, different personality disorders, and I feel like it all is coming out because of a lot of trauma that's unspoken of. But either way, I think it's really important that people do, whether it's long-term or temporary, at least know about these medications so they're not scared or intimidated by it.
Yes, especially for people that provide these medications, like stimulants, ADHD medications. People lose their minds.
Yeah.
Doctors, some doctors don't even prescribe them.
Yeah.
Pharmacies, they lose their mind too. When they see control medications, they're like, oh, what's going on?
Yeah.
That's why even new grads, NPs, even psych NPs, they are scared of those medications.
But why do you think that they're scared? Well, firstly, why did you start? Why Medication Mondays? Why did you want to do that?
Because I wanted to make people familiar with the medications.
Okay.
Give them at least 2 or 3 drugs to work with.
Okay.
For all the conditions.
To kind of familiarize them.
Yeah.
So that they're not, so when they do see it, they're not. Oh, they're like, oh, I know this. I know the things that it can do, the benefits of it, and some of the side effects.
And not only that, because there are so many medications for ADHD. Well, let's say for depression, example, there are so many medications for depression. So when you're a new grad coming out of school, you see the list, and you see some of the medications that are advertised on TV. So it's too many medications.
Yeah.
So that ends up overwhelming you. So now you feel like you gotta go back to the books to read up on all the medications, which you don't.
Yeah.
Because you need like one drug to work. One drug.
Yeah.
So what I'll do is I'll give people at least one drug for ADHD, for depression. If that doesn't work, do this one or do that one. Now, just 3 options, because people have so many options, that's why they get overwhelmed.
Yes.
Yeah.
I agree. Yes. Less options, the better.
Yeah, less is more.
Yeah.
Less is more all the time.
You don't need to know all of them. You just need to know some of them.
Yeah, just because you only need one to work.
Yes.
One to work.
Yes.
Because I've seen new grads prescribe medication, maybe prescribe like Zoloft. Then for 2 weeks, the patient come back and say, I'm still depressed.
Yeah.
And they're only taking Zoloft 25 milligrams.
Yeah.
Then they panic. They add another drug.
Yeah.
Panic, add another drug. No. Those drugs take time.
Yes.
For like the antidepressants take time to work.
Mm-hmm.
So starting at 25, it's like maybe kids. But I want to start like 25 to 50.
Mm-hmm.
Then the ideal dose is 100 milligrams.
Mm-hmm. So are you also going to teach, like, with the drugs that, like what you were saying, the Zoloft, that's what you were saying, right?
Yeah,
Zoloft.
yeah.
So
yeah.
would you also point out to the audience, like, okay, if it's not working by this time, don't switch to another drug, try this dose, and then try this dose, and then tell them if by a certain time this doesn't happen, then you may have to start considering another alternative. Okay.
Yeah, so people have to learn how to max out. Because what happens is the maximum for Zoloft is 200 milligrams.
20?
200 milligrams.
200.
200 is the maximum.
Okay.
So people start in 25 or 50. Mm-hmm. After 2 weeks, the patient comes and says, well, I'm not feeling any better. Mm-hmm. Then they panic and raise the dose up. Mm-hmm. First, you got to ask the patient, are you taking the medicine daily? Mm-hmm. That's number one. And I know people are scared to do that. It was a new grad. You're scared to ask the patient that.
Yeah.
What if you cuss them out?
Yeah.
Ask to find out.
You want to understand the regimen. Like, what are you doing something wrong, or is it the drug?
Yes. Are you taking the medication every day? They say yes. Are you taking the medication same time? Mm-hmm. They say yes. And they say yes, then maybe go up a dose. You don't want to just hurry up and just add something else. Because now you got 2 drugs that are like not ideal dose. Yeah. Then that's what we end up with something called polypharmacy. Yeah. Where someone is taking too many drugs. Yeah. Yeah.
So what about the people who, like, would you consider other factors? Like, okay, let's say, like, I know in the psych field, there's a lot of people who do have a history of, like, street drug use, right?
Yeah.
Would that affect it? Like, let's say they had years of doing drugs, street drugs, right? And then all of a sudden they stopped, and now they're trying to get right. Yeah. But I mean, are those factors to consider?
Yes. Those are the factors to consider. But at the same time, we don't want to punish people, because I know some people want to prescribe stimulants or something for people that used to use drugs before. Mm-hmm. But now we're kind of punishing the people. Mm-hmm. You got to consider that. Mm-hmm. Everything like smoking, like for like antipsychotics, like let's just take Xanax. Xanax, the good dose is 10 to 15 milligrams. Mm-hmm. But if someone smokes cigarettes, that 10 milligrams is not going to work.
You need to get higher.
So you want a higher dose, like 20.
So why would smoking, for the people who don't know, why would smoking affect Zyprexa? Because in their mind, they're like, well, it's two different things. One's respiratory and one is...
Which is the nicotine. The nicotine interacts negatively with the Zyprexa. So it makes it not as effective. So if you're taking 10 milligram Zyprexa, if you smoke cigarettes, it's almost like you're taking 2.5 milligrams. Mm-hmm. So you got to stop smoking cigarettes.
Yeah. Well, then not even that, because I that's the reason why I wanted to bring it up too, is because if they might think, oh, I'm not smoking anymore, but little do you know, they're taking other things that have nicotine. Like what is the vaping? Nicotine gum.
The vaping is much more dangerous.
Yeah.
Vaping, because cigarettes, you have to go outside to smoke cigarettes. Mm-hmm. You got, like, if it's cold, winter weather, you got to go outside with a coat, smoke cigarettes. But the vape is on your hand. It's right there, within reach. So you can vape anywhere. Yep. And the thing about vapes, when they came out, they said for you to quit smoking cigarettes, it was supposed to be a bridge to stop smoking cigarettes.
It's like, don't smoke anymore. We have a way. You can vape. It's much safer. But I've seen a lot of people actually who switched to vaping, and it actually ended up, they have a lot of acute respiratory distress, ARD. Yes. So
I know a guy who started to quit smoking by vaping. Then he couldn't stop vaping. So he ended up going back to vaping, cigarettes, to quit smoking. He ended up going back. Yeah. Mm.
Okay, so continue with the drugs that you wanted to start off with.
So we're going to talk about conduct disorder too. Mm-hmm. The condition that's also people with ADHD sometimes have conduct disorder too. So some of the medications work for ADHD, work for the conduct disorder. So we're going to talk about those drugs. Then depression, that's the main thing.
Okay.
Many new grads when they first come out. Many new grads when they first come out, when they first come into.
Okay.
Many new grads when they first start, they deal with depression and anxiety. So the main thing for depression and anxiety is antidepressants. We can talk about anxiety later on, but antidepressants are the mainstay. They work on both things. But sometimes we need someone to recover faster. So we may have to give them like a benzodiazepine.
Benzos.
Yeah. And that class too. So too, people are afraid of those things too.
Yes.
For a good reason.
Yeah. I mean, you hear stuff in nursing school, SSRIs,
Yeah.
like the things that you don't want to use anymore because they're old school. And
Yeah.
they're coming back now.
Yeah. and so benzodiazepines like Advance and clonopines, all those drugs, they are addictive. So there's other people are scared of them. But they have use too. They can be used. But some people are scared of them, afraid of them. Also talk about drugs for personality disorders, which is the main personality disorder that we see is a BPD, which is borderline personality disorder. We see a lot. I got a lot of patients with BPD, so many patients. You couldn't believe it. But the mainstay drug for that one is called Lamictal or lamotrigine. I used to be scared of that drug before. I used to be scared of it.
Why?
Because it's a rash called Stevens-Johnson syndrome. So we all know, but we get told about it at school. So because I know about the rash, I was like, I'm not prescribing that. But I've never seen it. Never seen it.
Yeah. So you've never seen it. How long have you been a Psych NP?
I've been a Psych NP for 7 years.
Okay. And you haven't seen it?
Never seen it.
Okay.
My collaborator, my doctor supervisor, he's been practicing for more than, I think maybe 50 years now. He's never seen it either.
But is it because you guys are considered like safe doctors? Like you do the proper protocol where it's like, okay, let's start small and work our way up?
Yeah, you gotta start small, especially with the Lamictal. You start 25 milligrams, 25 milligrams. So start 25 milligrams for 2 weeks. Outpatient. Then from 2 weeks, then go up to 50. Then 50, then you go to 100. 100 is a good dose. But some people might need 150 or 200. 100 is normally a good dose.
Would someone's diet and the way, like their weight or their height, would that affect the span or how long it takes affect the drug? Because like, let's say they're like, oh, and within 2 weeks they're like, I don't really feel anything, but really it was their body not really breaking it down.
Sometimes it can be some issues like that. So that's why even when you prescribe medication, there's also something called, there's the placebo effect. Like when we talk about drug, this is going to work. I'm confident this is going to work. So when someone believes it's going to work, it does work. But sometimes you just give someone a drug, just try this, maybe not. You're kind of thinking it. And they might not even take it as like they're supposed to. Yeah. But there's some issues with weight and height that can do that.
How about half-life? I mean, I know there's always a half-life for the drug, but is that necessarily the same for every person?
No, not necessarily the same for everyone. But that's why you got to take the medication around the same time.
So eliminate as much factors as you can.
Yes. For it to be therapeutic, you can't just take the medication today at 7 a.m., tomorrow at noon, next day at 5. So you got to take it at the same time, around the same time. That way, it's stable in your dose, it's in your bloodstream. Yeah. Otherwise, it's not gonna work.
Okay.
And also, we're gonna talk about PTSD.
Okay.
PTSD is so everywhere.
Yeah.
Everywhere. And it's not just people all associate PTSD with people that went to war.
Yeah, military.
Yeah. Or the next thing, women that face DV, domestic violence. But PTSD can be in a lot of places. So we're going to talk about that, the drugs to treat that, the first-line drugs, and the therapy too. With all the conditions that we have, we have to do some kind of therapy too. Because medication is not prescribed in a vacuum. I know some places, when you go there, see a doctor or NP, 10 minutes, it's done. They say, any side effects? No. He's prescription. See you next month, or see you in 6 months. And that can happen in 6 months. That can happen in 2 days.
Yeah.
And meds are not prescribed in a vacuum, so you got to find out what's going on with the person, the environment. Some kids with ADHD have conduct disorder.
Yeah.
And something might be happening around the family too. What's going on at school? So we got to provide supportive therapy for all the conditions.
Yeah.
Give them tips on what to do.
Well, that's good. And not just fully rely on medication.
Yeah, because medication is just a piece of the puzzle.
Yes. You got to find the deeper root to why.
Yeah. It's only a piece, not the whole thing.
That's good. That's good.
I remember one time, I was working at La Familia. I used to see kids. It was a nice place to go to start. So this woman, I prescribed her son some ADHD medication, and he went and took it. Then she came back maybe a month later. Said, "Well, the medication, he's still not smart." I'm like, "No, the medication's for him to sit still and concentrate. It's not for him to be smart."
Oh my goodness.
Yeah. And in my head, I'm thinking, if I had a drug that could make people smart, you think I'll be here? No, I will not be here. Yeah. So drugs are not a magic bullet. We put a lot on drugs.
And I think we are living in a world where that's what they do on, right? We are like a microwave generation where we want it now without making changes.
Yeah, right now.
Like I just need a quick fix and that's all.
Want right now. But no, it doesn't work that way.
No. And I usually, when I have patients, I like to give them the autonomy on whether they for different things.
Yes.
But also I don't hate on all drugs because they are helpful.
Yes.
I'm not trying to, but I'm not always trying to push, oh, you need more drugs. Oh, there's side effects. More drugs. Okay, let's find the deeper root, figure it out, and, take it from there. But you also have to the patient has to make changes too. Something that everybody probably has is diabetes. People who are diabetic, not diabetic ones, but people who have diabetes too. Some of them they're just on medications, pill form, or some of them have insulin.
Yes.
And I know people personally who will be like, I'm like, hey, you're not supposed to eat that. Like that's too sweet. Your sugar. No, it's okay. I took insulin. Ooh, that's not. Yeah, that's not how it works.
They depend too much on that corrective insulin. Yes. I'm gonna take my corrective insulin. No.
No, that's not.
Change, because you're gonna lose your leg.
Change your lifestyle.
You're gonna lose your leg. Yeah.
Yeah.
You're gonna lose your eyesight. Yeah.
Yes.
Yeah.
Yeah.
Yep. You're gonna lose your penis.
Yes.
But people don't understand. Yeah.
Yes.
Yeah.
Extremities different. Your toes. You're gonna get stuff chopped off. It's gonna start affecting other organs too. Yeah. People don't understand that. They don't understand.
And sometimes people don't need medication.
Yeah.
Sometimes people are just depressed.
Yeah.
And this can get over. Sometimes people need a job. if you're depressed,
they need those doors to open.
Yeah. Sometimes you're depressed because you got fired or whatever. You need a job. You need an antidepressant. You need a job. You need to get some money in your pocket first, okay?
Yes.
then if you're still depressed, then we're gonna talk about it, okay?
Yeah. Temporarily, not long term. Not long term. You don't need you don't want to be. Yeah, I get it.
Yeah, but they do use drugs. Are useful for sometimes. But it's just like the benzodiazepines. We're talking about quick fixes, because they make you feel good instantly.
Yeah.
So who doesn't want to feel good? I want to feel good too.
Yeah.
So if you just take it, you feel good without doing the work.
Yeah.
Otherwise, because before you want to use all the coping skills, those take time.
Yeah. But also, is there a cap for benzos?
Yeah.
Is there a cap where like they'll take it and they're like, oh, I don't feel it anymore.
Yeah, yes.
It's not working, so now we gotta go higher. And then higher.
Yeah, yeah. So that's why I tell people, no, it's like we can be on all the pains like that.
Mm-hmm.
These are coping mechanisms, okay?
Mm-hmm. Yeah.
Yeah.
Coping mechanisms.
The most I've got people on benzos is like maybe 2 milligrams, 1 milligram twice a day,
Mm-hmm.
which is Ativan, my go-to.
Mm-hmm.
It's not I don't like Xanax,
Mm-hmm.
but that's my go-to. I don't have any patient that take more than that,
Mm-hmm.
because it's going down a slippery slope.
I don't know if I really like. What's the alternative to benzodiazepines? Because in my head, if you take, let's say they've taken it long term, and they want to try taking themselves off, like you could get really sick.
Yeah. Oh, definitely. I've seen one time I saw this girl getting off Xanax. Oh my God, she was sweating. I can that scene in my head, forever in my head.
Yeah.
She was sweating. She was like all in sweat, like it was like she was the movie scene.
She was withdrawing.
Yeah, she was withdrawing.
Yeah.
Yeah.
She was.
I'm not doing Xanax at all.
The protocol for a person who's withdrawing from benzos is the same protocol you would use with someone who is withdrawing from alcohol.
Yeah.
And so one of the like if it gets really bad and they're starting to hear voices, they're starting to hallucinate, either auditory or visually or things like that, shaking, pain, all the things. We have been told to give them Librium.
Yeah, and also that Librium is also a benzodiazepine, is a controlled substance too. Yeah.
Mm-hmm. Mm-hmm.
So it's almost like it's the same class of people that are withdrawn from alcohol. We can let them just go down to zero.
Yeah.
One time because they'll die.
Yeah, it's a lot.
I used to work in the step down unit, so I used to keep bottles of alcohol beer in there.
What?
We did. All step units carry alcohol.
Instead of giving them Librium, you guys would give them little alcohols.
No, some of them come in, they like passed out. They call out. They have like a huge, amazing sales score is so off the charts. So they passed out.
Mm-hmm.
So if you let them just withdraw all the way down to zero, they'll die. They'll start having seizures and die.
Mm.
So a little alcohol, maybe, then benzos, then the other cocktails, then Librium. Then they can go. Because these people are in the ICU. Some of them came from ICU. So you can't just let them people just withdraw like that.
Yeah.
They'll die.
Yeah.
I tell people all the time, alcohol is the only drug you can die trying to get off. Cocaine, you might feel uncomfortable. You might feel like you're dying, but you're not going to die.
Yeah, you're not. You're not. It's just going to feel like...
Meth, you might feel like you're dying, but you're not going to die.
Fentanyl.
Yeah, fentanyl will kill. Just using it will kill. Yeah. But trying to get off alcohol, that's one drug that will kill you.
Yeah.
You'll die.
Yeah.
People still do it.
Mm-hmm. Because I feel like they're chasing that dopamine. You know what I mean? Like they want, I mean, like you said, like there's so much stuff going on in this world, people want to escape. And once they feel that feel good, they're like, oh, I want more. I want more.
They want to chase it, but that feeling is not going to come back again.
Yeah.
You're not going to catch it. That first high you get, you'll never get the high again. Never. But people we keep chasing. And because some of us, we only want to feel the good emotions.
Yeah. Yeah.
We run away from everything else.
Yep.
Anxiety, we run away. Let me take a benzo. Let me take this. No. Some feelings you got to face. Anxiety, I tell my patients all the time, feel it.
Mm-hmm.
Feel it. Unless it becomes overwhelming. Feel anxiety in your body. I also, the example I give them is that it's like lifting weights.
Mm-hmm.
When you first lift weights, a 10-pound weight is heavy.
Mm-hmm.
But after a while, you go to 20, go to 30. That's the anxiety. When you first get anxiety, it's overwhelming.
Yeah.
But when you don't run away from it, you feel it, let it go through you.
Yeah.
Next time that same anxiety comes, you don't feel it.
Yeah. Or it's better. Like you handle it better. Because your brain is creating new synapses to react to situations differently. You just got to keep learning. You got to keep learning.
But people just want to run away from feelings. No. Life, things are going to happen.
Yeah.
One thing I don't like the most, people come to me and say, oh, I could, like a chemical imbalance. Like,
how do you know?
Yeah, because they've been told by other doctors, like, oh, no. Or people say, oh, I got a broken brain. What's that? Yeah.
What's the problem?
Yeah.
Can you explain? What's a broken brain?
What are you talking about? And I've people come to me, throwing the big terms.
Yeah.
And I try to listen. Okay, then I try to tell them, no, that's not true.
Yeah.
Some of these things that they're told were proven false a long time ago. But people still run with them. Because pharmacists want to sell drugs. Someone says, well, if your mother dies, you just get depressed. You know, all of a sudden, like, have no serotonin in your brain. Because some people, I've seen people come to me and say, well, I think my serotonin in my brain is low, in my head, in my body. Like,
do you even know how serotonin works?
Like, what are you talking about? All the serotonin in your body lives in your gut. But people just come with all the terms. No.
Yeah.
That's why I keep it simple, explaining to people in a plain language. Yeah. That way they understand.
Yes. Yes. And in layman's terms and jargon.
Yes. No, we just use plain terms. If I use a big term, I break it down, explain what I mean. But I try to avoid that.
Yeah, no, that's good because people need to. Some people may not admit that they don't understand.
Oh, people don't understand all the time. You just sit there looking like a deer in the headlight. Because people are just throwing jargon.
Yeah.
But even the person that's saying those words, guess what? They don't understand them either. Because you understand something, you gotta break it down. The more you break it down, the more you understand it too. They were just told, just say mindfulness, just say grounding.
Yeah.
So they just don't understand that. They just tell people, hey, why don't you practice mindfulness? Yeah. And that's why people hide behind scrubs. Scrubs in the white coat. Like, I'm official now. No.
No, sometimes they don't even know what they're doing.
Most of the time, they don't know what to do.
Yeah.
All they do is wear scrubs because they think, oh, I got scrubs. That's the uniform.
Yeah. Yeah.
That's how they hide.
Yeah.
I come in plain clothes. And then people ask me, I want to tell people I'm an NP, I'm a Psych NP. Then because I'm not wearing scrubs, then they challenge me.
Yeah.
Oh, yeah? Oh, but this? Yeah. I tell them. Ask them a question, tell them.
Yeah.
Because I don't hide.
Yeah.
Wearing scrubs to me is hiding. Especially in the outpatient psychiatry, is hiding. Scrub in the white coat. Some people even had white coats and their name really known there. Like, what?
They have pride.
Yeah, that's just to hide. That's all. That's hiding. We don't hide. Yeah. Come meet people the way you are.
Yeah.
Let them challenge you.
Yeah. 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 No, I like that. I've met people who are higher above me, like doctors and stuff, and they don't know that, I'm a nurse or anything.
Yeah.
And the way that they would, I've had some really great ones recently, but way back when, they would use. Thankfully, I knew what they were saying. They would use big words and, like all these things. And I'm like, if I was a regular patient who didn't have any medical background,
yes,
I would just look at you and be like,
I know. But in all fairness, I think some doctors have been to medical school and now they're incapable of speaking to regular people. I saw this one lady, black doctor. She was talking all the good stuff about ADHD to patients. Hello, I can understand that. Then he says something, the mesolimbic pathway. I'm like, oh my God, patients don't understand that. That's when you lose people. She lost me as a practitioner myself. She lost me. Like, you can tell that to people.
Yeah.
People don't care about that. People don't care. They want to know is the medicine going to work? What pathway it takes, they don't care.
Yeah. Yeah.
So you got to learn to sell the benefits, not the features.
Yeah. Don't try to sound smart. Help them.
Yeah. That's most people do. Especially new grads. New grads always want to sound smart. Yeah. Because they don't know nothing, so they want to sound smart. use all these big words, which I don't know.
Yeah.
Yeah.
And then you have patients you're like, I don't know what you're saying. I don't know what this person's saying. I don't know what.
That's why I always recommend new grads with their first jobs should be like at a county clinic because you get more time with patients.
Yes. Instead of just rushing through it.
Yeah, because if you're a new grad, go work at a pill mill, or you're going to get burned out. Nobody wants a pill mill. Because you're supposed to see like one patient every 15 minutes. What can you do? Nothing.
Nothing. You just got to get through it.
Because by the time you recruit the patient starts to open up with you, time's up. They got to go.
Next. Like a cattle line. Like next. Next.
You burnt out. You've seen 20 patients a day. I know one NP, Psych NP, people called off for the job. One time he saw 55 people at the office.
In 8 hours.
Yeah, at the office. He saw 55 people. Yeah. And this is before the
And that's not even charting.
Yeah. This was before the pandemic too.
Oh my gosh.
At the office. How do you see those how many people?
No, that's great. And that you add video. People don't even have to go there. That's even more patients that no.
It's just you're exhausted. You have no life. Because you got to start too. Yeah, so you got to start too. There's too much. You burnt out. I barely see, like, the most I've seen in my practice is like 14 people a day.
That's good. You like it more personal.
Yeah. More personal, yeah, because you got to talk to folks.
Yeah. Yeah.
Because one thing I discovered as a nurse, I used to work at DBHC, Modesto. Patients will say to me, this is all day long. They're waiting for a doctor to come see them. Then doctors will come and see them for like 2 minutes. It's gone.
Yeah.
Then they think the doctor's come back. He's gone.
You saw him. That's schedule another visit.
That's it.
Yeah.
Because people like, hey, the doctor just greets you. Then he does a similar. Okay, he's I can see he's walking, talking to that. He's gone.
Yeah.
So you think he's going to see him again? No, he's not. So people just get angry about that. So that's why I say I'm going to give people all the time they need. Okay.
That's good. They're more able to relate and be heard.
Yeah.
So that's good.
Not all this pill mill thing, like every 10 minutes, 50 minutes, that's too much.
Yeah.
There's not enough money in the world to do that. I remember the one time, and I had 7 admissions in one day. I was no. I was exhausted.
Yeah.
My admission in 1 hour, so 7 hours. I was exhausted. But other people have admissions like 4 or 5 admissions every day for 2 weeks. It's not, you're not able to provide care like you're supposed to.
Yeah, I get it. I'm glad I'm here. I'm glad you invited me on. I'm glad I got to dig in your brain a little bit to ask questions and just more insight on the psych world. And I think a lot of people are going to benefit from that. So thank you for having me today.
You're welcome. Yeah. And so when I know you're going to go back to school to get your psych certification, okay?
I will let you know.
You gonna do it.
I will let you know. Yeah. If anything, I can just revert them to be, hey, if you need psych meds, you gotta talk to NP Moyo.
Because what's gonna happen is after you graduate from FMP school, with job is gonna be like, can you prescribe this medication, this psych meds?
Like, no, I don't do those.
Then the pharmacist, like the insurance company's like, nah, you can't.
You don't have a psych cert. Yeah. You can't.
Yeah. So then you gotta go back to school for that. So I'm gonna give you like, when do you graduate?
In a year and a half.
Yeah. I'll give you like 2 years to go back to school. It's only 1 year.
We'll see. We'll see. Maybe if you have me on more episodes, you can convince me.
Yeah. I got you. I got you. Yeah.
Okay. Yay. Thank you for having me.
You're welcome.